how do we how do we care for our patients in a holistic way? And we were together on the cancer committee, and we brought the question up: how can we be more cognizant of care overall? And John was there, Danielle was there, and we worked together. And then at some point we thought, well, APSA and palliative care would probably be a good collaboration on that, and also not only on surgical oncology, but on all the aspects of our care. So, there's more people coming in, so please take a chair and join the circle. And Howie is going to give you a little more perspective on that.
Oh. Yeah, so I guess the story started about 3 years ago. I mean, that's when we kind of work on this project. But at a surgical oncologist and maybe at a pediatric surgeon, you probably see a lot of patients who in a situation that you don't feel like you can help them. Whether the diagnosis is terminal, there's nothing to do, or you finish the operation and there's still not, there's no cure for the patient. And sometimes I felt like there's nothing I could do for the patient. But how do I maintain the relationship with them? How do I support the patient and the family? And you feel like what you're going to do. And some situations can be very difficult, right? The oncologist asks you to do something, the biopsy, the patient, or do certain procedure that you don't think going to offer any help. Maybe put the patient in a situation when they're suffering more. So that kind of distress. And anyway, I went to a period when I questioned what I was doing. But I came to a conclusion that when I look at a broader picture, not just taking care of the patient physically, but also look at the social cycle aspect and then the spiritual aspect, then I kind of found the answer for my question. So I proposed this to the cancer committee, and these friends right here who were very enthusiastic picked up the idea, and kind of we work on that. And I think after about 2.5 years, we had some kind of basic guideline of how we can help people go through this process. So that's what we're here today.
Well, we're all pediatric surgeons, so we love stories. So I thought I'd just start by telling a story of a patient who's very special to me, and his name is Quay Gray, and I met him when he was 17 years old. And he had desmoplastic small round blue cell tumor. And I was involved in his primary surgery, which was his cytoreductive surgery. And it was very successful. And this was after his neoadjuvant chemotherapy. And he was discharged from the hospital. He went home. He had his his radiation therapy, and he represented a couple months later with really terrible hemorrhagic cystitis. And he had CBI. It was not successful, and he had to go back to the operating room for about a 12-hour lysis. And then eventually, during that time, we did his cystectomy, and we had to do some urinary diversion. We left him with an open abdomen, and that was the first of many surgeries for him. 1.5 years later, he was still in hospital with an open abdomen. He was on TPN, and that was probably one of 7 surgeries for him. And he was cured from his surgery. Or from his cancer. It never came back. And so I guess that was a success. But I remember him begging me not to operate on him again and to actually let him die. And so at 19 years of age, we let him die. And I loved that boy. I really did, and not in some weird, gross way. But I remember kind of realizing that I totally missed the point, that even though we had cured him from cancer, we really, in another way, didn't help him at all. And I tell you this story because there's something so very important to learn from this patient. And I think about him often, probably once a month, maybe more than that. What we do as pediatric surgeons is so unique. It is so incredibly, incredibly special. We are so uniquely positioned, but we cannot do our job in isolation or alone. We need help, all of us, and we need help from other very talented professionals. And we are here today, accompanied by these talented professionals, to tell us what we do not know, because we cannot know it all. And so I'm privileged to introduce you to Danielle Cameron, who's going to introduce us to one of two cases to help us learn a little bit about what palliative care is and how we can work alongside our palliative care specialists to take better care of our complex patients who have life-limiting illness. So without further ado, I introduce you to Danielle Cameron.
Thank you. No. So the way that this is going to work is that we have two cases that are meant to be nice examples of where it could be appropriate to involve palliative care. And as I present this first case, you may immediately start to think, no, this sounds like a straightforward surgical oncology case. We're not talking about end-of-life care. We're not talking about comfort care or even necessarily goals of care. But the purpose of this first case is to really elucidate what goal concordant care means. And what was meant to be sort of a case scenario with role-playing, we decided as we were preparing for this session that, frankly, just an open discussion among colleagues is not only beneficial and educational, but sort of therapeutic. So as you hear things, if there's something that strikes a chord or that you have a question, especially of our expert panelists with dedicated palliative care training, please ask. This is meant to be interactive, and it's why you're sitting in a circle. I'll also take this moment to just introduce you to the card that's on your chair. This is something that you can hang on your hospital badge if you choose to. We have lots of extras, so if there's a palliative care liaison or colleague at your hospital that you think would benefit from having this, please feel free to ask for a second. And there's a QR code too that links to additional data, and I'll reference you to a paper that was recently published by my esteemed colleagues on this panel in Annals of Surgery on the topic.
And additional cards, if you don't have one, they're right behind there. So.
Take as many as we have, even more.
And because I see some very esteemed surgical oncologists in the audience, the purpose of this is really to talk about some of the non-oncologic details. So forgive me for being not too specific. So our first case is a 13-year-old girl who initially presented with low back pain and constipation. Ultimately, she was found to have a presacral mass that was biopsied and confirmed to be Ewing sarcoma. A staging workup demonstrated no evidence of metastatic disease, and she was subsequently started on neoadjuvant chemotherapy with a phenomenal response. The mass shrunk from 7 to 3 centimeters on repeat imaging. She presented to our institution for discussion of local control, which for any of you who don't take care of patients with Ewing sarcoma, really the debate was, is this resectable? And local control could be achieved with surgery, with the goal of negative margins, versus radiation. The considerations for that were that this was a mass closely abutting the rectum. There was the possibility that achieving negative margins would require a low anterior resection, and in the setting of the potential for radiation, that could likely require diverting ileostomy. The considerations for radiation were that there are complications associated with radiation, like cystitis, incontinence, and certainly the longer-term risk of secondary malignancy, which for a young patient is important, and it can cause lifelong anxiety, let alone the cancer itself and the subsequent treatment. So given the location of the tumor, the fact that this was a 13-year-old girl who also had some psychiatric issues that had been closely followed. There was a lot of family anxiety about what an extensive operation might entail and whether or not she would cooperate with postoperative recovery. So I'll start by asking my friend and colleague, Amy, how would you even approach a patient like this, and what's the role of palliative care here?
So to start, I would say the fact that you're asking the question is a really important first step. I think when in contexts like this young girl's case, often the immediate thought isn't, oh, let's talk to palliative care, because perhaps her outcome may be very good and her prognosis may not actually be that bad. And involving pediatric palliative care early in a patient's story, when potential interventions may have big impact on her life and her experience through adolescence and young adulthood, and her prognosis may change over time and worsen as things play out, can be really helpful, because pediatric palliative care can be a key, set of experts in figuring out what's most important to any child with serious illness, whether prognosis is really poor or maybe not so poor, and then helping the surgical team to figure out, okay, based on what's most important to the patient and the family, what is our medical recommendation that aligns with those values and those goals? So I would say, thank you for even thinking to get in touch with us. And I think the first step is probably our team sitting down with the family, even separate from the surgical team, to start having those conversations about who this young girl is and who her family is and what matters to them. Yeah, so I think a lot of times when people hear palliative care, both on the doctor side or the clinician side, I should say, and on the patient and family side, they say, whoa, hospice? Like, I thought you said that surgery went okay. And I think that is a common misconception, that palliative care is hospice. And in a lot of instances, palliative care is a team that walks with patients and families and the medical team throughout an entire illness trajectory. And in pediatric palliative care, we talk about that from the time, sometimes before even diagnosis, all the way through either cure or bereavement, depending on directionality. And so it's a team that never replaces any other medical team. So the primary medical team stays the primary medical team. And we just provide an extra layer of support to help figure out iteratively over time what really matters and how do we make sure that whatever treatment is being recommended aligns with those things that matter most. So we usually talk to the family about walking with them.
Sometimes I would describe to families that palliative helps with patients that have life-limiting or life-altering diseases. And I think the latter is more about grief. So if you were anticipating a life without an ostomy, or to have a full standard duration of your lifespan, and you're now looking at potentially shortening that and a lot of suffering along the way, there is grief in that experience. And I think palliative, not just the physicians and the nurse practitioners and other advanced practice providers, but the chaplains and social workers who come with, really are comfortable in that space and naming that that's what they're experiencing.
And I think that, as has been mentioned, palliative care are experts in communication, and they also have the luxury of time, which is not always the case for a pediatric surgeon. I'm sure we would all like the opportunity to sit and speak with our patients and have hours-long consultations to really understand where patients and families are coming from, and yet we don't always have that time. And the palliative care team can be a resource and a tool to help bridge that understanding with families. And they can help illuminate things like what this 13-year-old may be wondering, like, how am I going to participate in my dance show with an ostomy? And how can I even think about fertility? I'm 13. What does that mean to think about not being able to have children as an adult? And I think sometimes those questions, they can get lost when we're really focused on curative treatment or supportive treatment.
I think in the context of surgical oncology too, we've talked as a group about how I think we're very fortunate as surgeons that patients and their families will look to us as their doctor and the captain of the ship, the one that's going to fix the problem. And one of the reasons I became a pediatric surgeon was my mentors and teachers and ultimately friends were the really nice surgeons, the surgeons that cared to sit down and talk for an hour with a patient and get texts from families down the road with birthday cakes and happy news. And so we're not really the surgeons that just come in and do the operation and leave and let the palliative care doctors have the hard conversation. We have the hard conversations too. But understanding the full capacity of where the team approach can really enhance the patient's experience. The other thing I'll add, which is a little less relevant to the first case and perhaps more relevant to the second, is that really understanding what parents or patients, if they're able to speak for themselves, want, and especially if they're at the end of their life and we're challenged with having to perform an operation that we think might be futile or could even precipitate death. If there's been a lot of effort and discussion and clarity about what goal concordant care looks like for that family, and you're doing an operation that you know may not ultimately result in success, meaning life or improvement, you've still done something for the family. And the role of the palliative care team can benefit the surgeon too, because they've helped to clarify what goal concordant care looks like. And so some of our moral distress and losing patients and doing harmful things like surgery can be reconciled at least a bit by knowing that this was consistent with what a family wanted. And while it's painful, and we certainly all carry a personal graveyard, I do think that there's benefit to everyone on the team. You want to do your second case? Sure.
Reflections.
Second case is a little beefier, so.
Okay.
Anything, I guess another way of saying it, anyone, as we're talking about these concepts, does any of it resonate with patients you've taken care of, cases you've been involved in, we've worked with palliative care teams? Anything to share about your own experiences?
So I would have the question, does every children's hospital have, well, I know they have ethical committees that you can call for, but do you think it's easy for pediatric surgeon to call for an ethical and palliative care consultation in every single hospital?
So no, not every hospital, pediatric hospital across the country has a palliative care program, though the numbers have increased significantly in the last 10 years probably, and even more so over the last 20. And there was a recent study published saying where there is pediatric palliative care access and where there's not. And I think programs continue to start evolving. And one of the things that's interesting and beneficial and also kind of challenging about building a pediatric palliative care resource in a hospital, in a children's hospital, is it's not just a doctor, it's a doctor, a nurse practitioner, a social worker, collaboration with chaplaincy. And so building that interdisciplinary, interprofessional collaboration takes some time. But I think when there is a pediatric palliative care presence in a pediatric hospital, that team is usually very excited to talk with the surgery team. So any surgeon that calls and says, hey, would you want to talk through how I'm thinking about treatment recommendations for this patient in the context of their family, would be really excited about that call. Sorry. Does that answer your question?
Yeah.
Okay.
So we work I'm in Tacoma, Washington. I'm very fortunate to have a palliative care team. And I have found that the relationship between the surgeons and the palliative care team is actually excellent. It's the medical teams occasionally with the palliative care teams where I see conflict.
Interesting.
And I didn't know if that's something that you guys have registered, especially with like the PICU and the hospitalists. PICU, great thing there, but I don't know. Is that something you guys experience? Because this is a specific surgical oncological case, but change it to ECMO, change it to something where the medical teams are heavily involved, and all of a sudden it's a weird, Oh, thank you, thank you. I was just saying that I've seen conflict with the medical teams and the palliative care team, and not necessarily the surgical team. And often these kids in these cases are multidisciplinary. So I was just wondering if you had seen that.
Yeah. I think you bring up such a good point that figuring out the dynamics between different medical teams or surgical teams and the palliative care team sometimes takes time. It's not like an automatic, okay, we provide this technology and you ask for this technology and we provide it. It has to do with an interplay and a rapport. And when you're building a pediatric palliative care team, sometimes it takes time to build that working relationship. And so I think as programs emerge around the country, different services collaborate in different ways. And as a surgery team, it might take some guess and check to figure out, or in your case, in the medical team, what the ideal dynamic is. And that's one thing that pediatric palliative care teams are also very excited to think about and work on with the partner team.
The other thing I would say is that there is this concept of primary versus specialty palliative care. And primary palliative care are things that all of us do as physicians, and particularly, I would say, as surgeons. We establish goals of care, we make recommendations, we provide empathy, we treat really challenging symptoms. All physicians do that. And specialty palliative care are things that only the palliative care team can do. That comes with the chaplain, that comes with a huge toolbox of pain management that we don't even think of, like a lidocaine infusion. And so I think that there's this misconception sometimes in the ICU that we don't need palliative care because we know how to have goals of care conversations. We've established trust with the family. We don't need another team coming in here and making them talk about death when they don't want to talk about death. They want to have hope. But the problem, I think, in that is that the specialty palliative care team provides so many additional resources, both in the ICU and whatever comes next, in terms of signing up for bereavement support or figuring out who they might be seeing in clinic after they leave the ICU and preparing for that next chapter, which I feel like sometimes gets lost in the immediacy of what's going on in the ICU. And so I think, naming that as surgeons, we provide palliative care all the time, and so do our ICU colleagues, but it's a different skill set that the palliative care team can supplement what we're already doing.
I was just going to add a historical perspective, since I know ABSA loves their history, which is that the field of pediatric palliative care, much like the adult field of palliative care, was sort of born out of pediatric oncology. And so historically, there really was a bent towards oncology. And I do wonder sometimes whether acceptance in the PICU and the NICU has taken more time, because historically many of the first pediatric palliative care trained physicians or practitioners came from pediatric oncology. And so they sort of have a head start in the oncologic world in integrating pediatric palliative care. And it's been sometimes institution dependent, a little bit slower in some of the other specialties. But I think Amy made the good point that it really depends institution to institution. And that's the beauty of palliative care, is that the clinicians are, part of their skill set is figuring out maybe why teams are reluctant to use their consultation, and then trying to understand that and ameliorate both by proving what they can do to help, and also trying to, I guess, have other teams understand the purpose of palliative care. And I think now we'll move on to our second case.
So for our second case, we're going to talk about a baby who we took care of, who was born as a mono twin at 30 weeks, had a known prenatal diagnosis of an anorectal malformation, but at the time of delivery was found to have essentially non-functioning pelvic kidneys, and made no urine, and then was found to have a cloaca. And so our team was consulted to discuss the possibility of diverting with an ostomy and placing a hemodialysis line, understanding that this child was also 1 kilogram, and it was one of the younger, she's the youngest patient we've put on Carpe Diem CRRT. And so the question I would ask to start is, when you are called to talk to a family about a new diagnosis, there's this unique thing in our field, in our job, where we get to meet parents that have just gone through the adrenaline rush of their life of having a child, and how you talk about a new difficult diagnosis with families that they weren't expecting. Anyone? Yeah.
So the thing that we start with, and some of you may have heard this in real time, is we don't talk at all about the diagnosis. So if, let's say it's a newborn in the NICU, and they've just heard this terrible diagnosis from the NICU team or from the surgical team, we ask about their child as a person. So if that's a newborn, we often say, tell me about the story of how your child came to have the name she has or he has. Tell me about who your child is within your family and the other people who are in your family. And we start with that question because often when a parent is going through something like this in the hospital, no one's ever asked them who their kid is. They've told them about their kid based on medical interpretation of their child's health status. And from that question, we say, so, thank you for sharing with me about your child. What has the medical team shared with you so far about what's going on? And that's trying to get at a sense of their not only understanding, but also their awareness of what's happening and what the team is worried about. And we say, in light of everything that you're telling us that the medical team has shared with you, what are you most hoping for right now? And what are you most worried about? And we're trying to really discern, what's weighing on them and what's their best case scenario. And we often ask the hope question a few times. So it's like, what are you hoping for? And maybe they'll say that my child, has full surgical repair and lives to be 100. I'm exaggerating. And then what else are you hoping for? And what else are you hoping for at level? So we're trying to hear, what are you hoping for today? And what are you hoping for this month? And what's your big picture? And sort of getting at a sense of all of that. And then we move on to say, and how are you getting by? What's allowing you to do this work of parenting your child amidst uncertainty and adversity? And people share all different kinds of tools and sources of strength. And then how are you getting by practically? What's this doing to your capacity to have food, transportation, a place to stay, housing, and get at that level of resources? And the idea is that this whole conversation happens separate from the diagnosis conversation. So it's giving them a place to begin in thinking about their child's experience from this broader perspective.
So I'm just going to comment because I did a prenatal consultation for this family. So this is a baby that only survived in utero because she was a mono twin. So basically, her sister was her dialysis system. So prenatally, we knew she had a cloaca. I talked to the mom, and we suspected that there was something wrong with her kidneys, but we didn't know how bad it was. So when we counseled the mother, we said the most important thing will be how is her kidney function, because that will depend survival or not. So suddenly the mom delivers early. She has one perfect twin and one twin with no kidney function, 1 kilogram. And I was traveling, so I was not in that discussion. But what I know is that the family knew how bad the prognosis was, to a point that she didn't want to interact with the baby with cloaca because she knew about the possibility of not survival. And I was not part of the discussion. My fellow was, Alexa was. But I think if I was there, I would try to be clear that the chance of survival was close to 0. And I don't know, Alexa can tell more how much the family was really informed about, and then how much should we do? And for us as surgeons, it's kind of easier to take the train and keep going and offering treatment because we say, well, I did a colostomy, patient did great. Patient didn't die because of the colostomy. But the reality is, did we really benefit the patient making a colostomy and trying to do dialysis in a 1 kilo baby? I don't remember how much she survived, but Alexa can tell.
I'm going to throw out a very provocative question. Should you have palliative care involved in prenatal diagnosis and discussion? So I'll give it to Ryan if you want to comment on that.
Sure. Not surprisingly, to your question earlier, Dr. Bischoff, so many of our hospitals, even that do have pediatric palliative care, they're so overworked, right, and understaffed. And so to get these sort of consultations is incredibly difficult. I wrote a paper 2 years ago basically saying that every fetal center really should have palliative care person in these conversations. I do most of our consultations for congenital diaphragmatic hernia. I'm sure many of you are involved with these. It's just information overload. There's a 30% chance of this. There's a 40% chance of this. If we do go on ECMO and you come off, but we have to go back on, then there's this chance of that. If it's right side versus left side, and the parents are just like overwhelmed with this information. And it's kind of like, we just got to wait and see, and then we'll do to your point, as opposed to stepping back and trying to figure out where are we going, what's our best case, what's the worst case, and how can we walk with you throughout this journey so that there's not eventually conflict. Because at least at our institution, I feel like a lot of times palliatives eventually brought into the picture is for conflict resolution, because the team doesn't want to do that second run of ECMO, but the family wants to do it because this paper out of a certain institution had results or whatnot, right? We run into this all the time. And so sure, they're helpful for mitigation, but we need to do like preventative work ahead of time. And so that's where I really argued that to have the expertise of our colleagues like Amy up front helping even in these multidisciplinary consultations for these very complex, very sick fetuses helps us so that from day one to week one, that we have that sort of continuity and we're on the right path. Not that like, now the family's mad at us, call palliative, call ethics. We just need someone to mitigate and take care of the problem. But I would say like preventative palliative care, if that's such a thing. So I'm not sure if others in your institutions have this sort of upfront approach, or if your resources are so stretched as well that we end up doing it. And I guess that's another point that our group has talked a lot about. Our responsibility for our trainees to provide them with tools. They all can't do a palliative care fellowship like Alexa, but what are we doing in our fellowship programs to provide them with some simple tools when they are the sole provider talking to families with complex conditions, when they don't have someone as resourceful as Amy available. So I'm curious what other folks are doing in your institutions.
Well, I can tell from my experience, I'm not trained in palliative care, and I'm not that smart either. So if I can figure it out, I'm sure you can figure it out. But the way I approach these problems, and hopefully answer some of your question, the term palliative care is mean that you relieve suffering both in physical, right? So that the medical aspect, that what we do, the psychosocial aspect, and then the spiritual. So don't forget that, right? I think a lot of time we kind of get so focused on the medical aspect. There's nothing we can do, or there's something I can do. Why don't you let me do it, right? So either way, the parent who doesn't want to do things for their child, but you saying, oh, there's a good chance we can fix it. So you got to get into the conflict in that situation too. So either way is a problem. But because we hadn't taken into account of the social and psycho aspect, right? How is that care, that treatment, that procedure do affect them in terms of their family dynamic, the situation, or what their value gonna be? Do they want a child who's become like that, right? Do they want a child who have certain defect? How does that affect their spiritual belief? So those kind of things we have to take into consideration in order for us to understand why the parent want to do certain thing. And I want to go back to your point too, because even our medical team, some team understand that, and some team may only understand one or two aspects instead of all three of them. And that's why I think we get into conflict, because we were so focused on one or two area and maybe, not, intentionally or not, but like we don't think about the other aspect, which I think the spiritual aspect, probably the most difficult aspect to grasp. I have to say that's something that I struggled with before, to understand that, because some parents they want to do everything and then you don't know why, right? But when you talk to them, you understand actually there's a good reason for them to do it. So I just want to say, I'm a poor version, palliative care, okay, poor man version. So very simple, basic, just think about the three aspects, right? What I do medically, are they going to help the patient, right? You know the risk and the benefit of those things. I think we kind of train on that aspect. Socially, how does that affect the patient and their family and us and our team? And then spiritually, what is your belief? Sometimes we have certain belief that we think is not concordant with the parent belief, and we use that to judge them, right? So we have to let go of that, understand what their belief is going to be. So all three aspects.
I think we'll give it back to Alexa for the continued story.
So the only pushback I would have is about why we're doing this surgery for no benefit. And I think that people talk, as soon as a diagnosis like this comes up, the concept of futility comes up a lot. And I would just push back on that word a little bit, because there's three different types of futility. There's physiologic futility. If you've been beheaded, we cannot get the blood up there. If you have quantitative futility, that's in terms of could you live for minutes, for hours, for years? And then there's qualitative futility in terms of, will you be able to interact? What kind of experiences will you be able to have? And inherently, the quantitative and qualitative are value judgments. And so what I think is futile, someone else might not. And so for this family, they kept saying to me, everyone is giving me a buffet of options because they don't want to take the choice from me. But I cannot make this decision. I need you to help me make this decision. And so I think when someone says that to you, what I come back to is trying to figure out what are their goals so I can make a recommendation. And the questions I like to ask are similar to what you're describing. What are you hoping for? What are you worried about? What are you expecting to happen? What would be unacceptable to you? And asking those same questions often multiple times can help to elucidate that. And what I found from parents in asking those questions is they said, I don't want her to die suddenly. She was just born. I need time with her. I want her to have some time with her sister. And I know she won't live long, but I'm running on the adrenaline rush of just having had a C-section. I can't live with the fact that she might die without me there. And so that made it easy for me to say, well, dialysis makes sense to me then, because if your potassium is already 6, you will suddenly die of a cardiac event. And I may not be able to prevent that with a dialysis run. I'm not even sure we're going to get this 6 French into the 1 kilogram baby. But the risks of taking this on makes sense because you want some time, even if it's short. And same with the decision about to divert or not because of the potential for perforation. So I think what our role as surgeons is in the palliative world is to take the time to get to know what matters and then to be able to say, my recommendation based on getting to know you is that we do this. And if it lands and doesn't feel right, then tell me about that and we'll hash out if this is the right path. But I'm not going to leave that decision on your shoulders. I'm going to be there with you to help you figure that out. But I would just say that for this family, not to give away the ending, but she died about 3 weeks later. And I went back to speak with them to try to figure out, was the time that we could give you what you were expecting? And they were immensely grateful for the time that they did have, even though it was a very trying 3 weeks and there were a lot of setbacks and other things. But their twins had 3 weeks together and they had 3 weeks to know their daughter. And so while many people in the ICU continued to say, this is futile, there's no benefit to this, why are we doing all of this? What are these resources going towards? For this family, this was quality time. So I think, and I don't know if you have some comments about that. Yeah.
And maybe, I don't know if this is for you, Alexa, or maybe for you. Does it get a little muddy when we think about a patient as an individual or a patient as a family unit in pediatrics, when we think about making decisions for the best interest of a patient, when we're thinking about dialysis and prolonging life or prolonging suffering? Because here we're making a decision of prolonging life for a patient who is, we know she's going to die, and we're running dialysis and extending her life for 3 weeks, which is extremely meaningful for the family, and extending life and allowing the family to cope with the coming to terms with her death, and allowing those sisters to have that time together, and bonding as a family unit. But do you know what I'm getting at? And I'm just wondering, how do we reconcile that as an individual patient, suffering, and family unit?
Sure. Thank you so much. I'm going to move over here so I don't have to walk through the group entirely. My name is Charles Bagwell, and I'm a pediatric surgeon, and I have been doing sort of palliative care and pastoral counseling for a long, long time. And I really applaud the comments that all of you have made. And as I'm sitting here nodding, because Lisa, we all have our quay-quays. We carry them with us. And that's why we're probably sitting around this group here today, focusing on what you just said. I'm sorry, I didn't get your name. Alexa. That this isn't a Wilms tumor or a Ewing sarcoma. This is a child and a family that have this condition. And what I found is such an effective way to deal with them is to sit down and carry on this conversation, like you said, of just talking about life. What's your child's name? That's a beautiful name. Where did that come from? And as we begin to instill a bit of trust in me, not only as a surgeon, but somebody that cares about you and your family and your child, to begin to break it to them, we have a journey ahead of us. And we will help you in this journey, but I'm not driving the bus. You largely are. My goal is to try and help you. And together we will make this journey, but you have to tell me how you want that journey to go. And it will take side routes, and there will be flat tires and so forth, but I will be here on that journey with you. I promise you that. And we will get through it. And my faith, you can use this for any of your faith, it doesn't really matter, is that this will all be okay in the end, because it will be. As you pointed out, that faith that we carry with us as being the core of our beliefs, we're going to talk about this tomorrow, and it's a source of so much strength that we're going to get through this and it's all going to be okay in the end. I believe that. And I can't tell you how many times families haven't gotten through the Quay incidents, and me as well, based on that as being kind of a promise. Thank you.
Yeah, and I think that's part of what we try to do by asking families, like, what are the ways you are going to, like, what are the tools you might use through this to get through this? Is it focusing on things may be okay in the end? Is it moving day by day or hour by hour and not thinking ahead to the next step? Like, what are the strategies that they're employing? The question about suffering and a baby's potential suffering or a 13-year-old's potential suffering, I think that one thing we try to sort of illuminate among teams is that suffering is a shared experience a lot of the time and a collective thing. So there is maybe the pain in a child or other symptoms in a child, and there's existential distress in the child, and there's existential distress in the parents. And then the team also has distress, and especially when any one of those groups feels uncertain or conflicted about what's happening with the patient or what the next step is with the patient, they can feel suffering and distress. So sometimes it starts with naming, like, we are feeling distress because we're worried that this baby may be in pain, given what we've decided to continue supporting life at this time. What are we doing medically to treat that pain? And how does that help us think about the baby's distress, the family's distress, our distress as the medical team, knowing that these strategies are in place? And I think picking apart the different sources of the collective distress can be an important, first step in addressing some of that uncertainty.
Yeah.
Hi, I'm Farouk Demary. I'm from Boston Children's, and I'm not a surgical oncologist, but I'm an intensivist, and I thank you guys. This is so amazing. A lot of heartstrings are being pulled and memories are being pulled. One recent thing that I would love to ask your opinions on is, we talked about, grief and hope, and how we're treating a family in addition to a patient, and how spirituality is so important for certain patients. How do you navigate it when the family has discordance among themselves? Recently had a patient was on ECMO, they weren't going to make it. Mom refused to believe that, understandably. Grandma pulls me aside at night in tears, asking for my help to help her daughter realize that. Dad has a different opinion. How do you navigate it when the important people in that child's life have different faiths or beliefs, etc.?
That's a really good question. And it's fascinating because, I think the context too, when we talk about hope, right? So I spent 2 years in a small little hospital in Philadelphia who has a nice marketing slogan, "Hope lives here," right? So we're our marketers and administrators are setting us up, right? The miracle will happen. Farouk will save your kid if you just go to Boston Children's, right? So of course, they're expecting a miracle, right? And then when that miracle doesn't happen, how do you navigate this? I wanted to bring this back to our earlier discussion where it's thinking through the family versus the child. I'll push back a little bit that on the one hand, of course, we take families and their considerations into account. All of us who have our own children, kids have to take sacrifices and ride to the older sister's ballet class, even though they don't want to, right? Everybody sacrifices for the family. It's how families work. And yet, as pediatric surgeons, yes, we're caring for families, but we also have this patient that's at that center. And I think sometimes I've noticed from some of our adult colleagues that sometimes shifts the emphasis. And so this emphasis on family-centered care. I don't know the right answer. I'm just trying to be a little provocative, but should it be family-centered care? Or should it be this patient-centered care with consideration of the family? And if that's the case, do you have to get perfect concordance among the family members, or understanding their differences and what's driving those things? Can you come back to ultimately whether it's what's best for this child? Are we harming this child? Because some parents don't want their child to go. Should we do dialysis on everyone just so they can have 1 more week or 2 more weeks? I don't know, right? There might be some limitations to that, and we might be causing suffering or harm, which we don't think is best for our patient. And we have to help the families rally around what's best and for your child too. So I'm curious what other people think. I'm trying to push that a little bit.
I was just going to say, to that difficult situation that you described, I think even on the palliative care team, there are times when we realize that that family is not going to come to a consensus. And sometimes the acceptance that children are going to die and their families are going to be angry and upset and feel as though this was not, quote, a good death, that there maybe is no child's death can be, quote, a good death. And I think that sometimes there's no way to have that mother accept that her child will not survive. And it's something as a palliative care team that is really hard to accept, because as a team, we pride ourselves on trying to bring that acceptance or that at least concordance to a family and to a team. And the cases where it can't happen are really upsetting. And sometimes it is the medical team. Sometimes we can think of our role as holding some of that distress for that family, that being there and witnessing how difficult it is for that mother to realize that her child is not going to survive, that is actually just bearing witness can be a help to that family, which is not the answer I think that we all want. I'm aware of our time, and I appreciate everyone's engagement in this session, and we were so excited to be here and be able to talk about this topic. I think just to take some things away, they're mostly on this card, but just being here today, I hope, makes everyone in the pediatric surgery community realize that pediatric palliative care has a lot to offer, and also all the palliative care skills that all of you are already using in your practice. So, our card says it all, but palliative care really can help families and patients and physicians, pediatric surgeons, figure out what is most important and how to deliver that care in the best way possible. So feel free to we have lots of extras. So if you'd like to take some for your institution at home, and you can check out, we have a digital version in our QR code with more resources, which are not listed up there, but are here, including some, if you're interested in learning more formal tools, some ways to think about palliative care for pediatric surgeons.
And the idea is you could hang it on your, your work name tag and glance at it if you need to introduce pediatric palliative care to a patient or family, or even talk about it with a team that's not used to collaborating. So please use it as a resource.
Leadership allowed us to put the APSA logo on it. So, and if you think it was interesting, please speak around you, and maybe we'll get a more formal time next year at the meeting to talk about that. If you think it's interesting, but please bring some of the cards home and talk about it around. Any comments, feedback? It's too short in my mind, but
yeah. Thank you.
One shout out to Amy's boss, who actually paid for her to come here on their budget, because that did not support the travel, which is understandable. But thank you to your boss, and thank you for coming. Yeah. And she took her call, so.
Yeah.
Should send that thank you note.
Yes.